Welcome to AETCM, the Emergency Medicine Channel. Today, let us discuss about myocardial infarction. Myocardial infarction means infarction of myocardial muscles that may be due to reduced blood supply to the muscles. Before going to myocardial infarction, all chest pains in emergency room is not myocardial infarction. There are a lot of other reasons for myocardial infarction. It starts from emotional conditions like stress, fear, or gastric conditions like GERD, esophageal spasm, Mallory-Weiss syndrome, musculoskeletal conditions like osteochondritis, rib fracture, rib injury, neurological conditions like herpes zoster. That is one of the most important condition in especially in diabetic patients. Whenever a diabetic patient come with left-sided chest pain, you have to always examine the skin of the patient because there will be high chance of herpes zoster in that dermatome. So we have to examine that in detail. And when you take cardiac causes for chest pain, again there are multiple reasons like myocarditis, pericarditis, mitral valve prolapse, aortic stenosis, aortic dissection, aortic aneurysm. All these things can produce chest pain. But one of the most important condition you should never miss is myocardial ischemia or myocardial infarction. Ischemia is partial obstruction of a blood vessel, like something like this. This is suppose this is ischemia. Is a plaque which is obstructing the artery, partially obstructing the artery, so that reduces the blood supply. Whereas myocardial infarction means by the plaque it is completely obstructed. So what happens? The blood supply is cut after this, and myocardium will suffer. Uh, Complete blood supply will be cut off to that area, and that area will die. That is necrosis and death of the tissue. So that is the difference between angina and infarction. Now, if you define the myocardial infarction, it's a clinical event produced by myocardial ischemia in which there is evidence of myocardial injury or necrosis. How you get evidence by clinical examination? That is not possible. Patient can have severe chest pain, palpitation, anxiety, fear, sweating. All these things you can get in both unstable angina and myocardial infarction. But myocardial infarction, cardiac enzymes will be elevated. That is very important. Myocardial injury and death will lead to injury of myocardium, and death of the myocardial tissue will lead to elevation in the cardiac enzymes like troponin I, troponin T, CKMB, like that. Now, when you classify the acute coronary syndrome, you can classify it into major groups. One is myocardial infarction, other one is unstable angina. Unstable angina means there is a partial obstruction of the coronary, but whenever there is stress, strain, or anxiety, fear, exercise, this demand of the myocardium increases, and that produces chest pain. Whereas in myocardial infarction, there is complete obstruction of the arteries. That is very important. In myocardial infarction, there are two types: ST elevation myocardial infarction or non-ST elevation myocardial infarction. That all depends on the ECG changes. So, how do you differentiate myocardial infarction from an unstable angina? Unstable angina, cardiac enzymes are not elevated, whereas in myocardial infarction, cardiac enzymes are elevated. Now, that is a classification of acute coronary syndrome. What is a typical feature of myocardial infarction? Pain can be there, diffused chest pain on the left side, or sometimes central chest pain, or sometimes epigastric pain that may radiate up to the mandible and the left ear. Then it radiates to the left shoulder through the medial aspect towards the tip of the left hand. That is a typical feature of ischemic heart disease, ischemic chest pain. So you can see here there is a coronary artery. That lumen is full normal here. In that lumen there is a obstruction which is formed here. So what happens is this obstruction will increase in size, and sometimes it can completely block the myocardium. So that produces complete obstruction of the artery that will lead to acute myocardial infarction. So that is very important. What are the symptoms of myocardial infarction? Severe chest pain, which may not be relieved by rest or sublingual nitrate. That is very important. Then the chest pain can radiate, like what we have seen in the previous slide. It can radiate to various areas. Then associated with that, patient can have anxiety, fear, impending death fear, and severe sweating, nausea, vomiting, breathlessness, syncope, collapse. All these things can also be associated with myocardial infarction because of the complications. Now, what are the signs? Signs are very, very important because both in myocardial infarction and ischemic heart disease, you can get it. But other conditions, what we have explained in the previous first slide, the differential diagnosis for chest pain, that may not be there. Sympathetic activation like pallor, sweating, tachycardia, anxiety, fear, then signs of vagal activations like vomiting, sometimes bradycardia will be there. So most of the time it will be tachycardia, but vagal activation, especially in the low inferior wall MI, you can get bradycardia. Then impaired myocardial function can lead to hypotension, shock, low pulse rate, low pulse volume, raised JVP, and S3. All these things can be there. Signs of tissue damage that occurs after 1 or 2 days. Patient can have high degree fever. Signs of complication like when you auscultate, you get pansystolic murmur due to mitral regurgitation, pericardial rub due to Dressler's syndrome or pericarditis. So many things can be there. Now, when you talk about acute coronary syndrome, we have already seen that acute coronary syndrome is divided into myocardial infarction and unstable angina. In myocardial infarction, again, ST segment elevation MI, ST segment non-ST segment elevation, non-ST segment elevation MI. So all these things are diagnosed only on the basis of CKMB, troponin I, troponin T elevation. So that is also very important. Now, what is ST segment elevation? ST segment elevation means a new ST segment elevation at J point in two contiguous leads like V1, V2, V3, V4, V5, V6, like that, two contiguous leads, or 2, 3 or 3 AVF, like that. ST segment elevation cutoff points 0.1 millivolt in all leads other than V2 and V3. For lead V2, V3, the following cutoff points can be considered: more than 2 millivolts in men and more than men over 40 years, more than 2.5 millivolts in men less than 40 years, and in women it is more than 1.5 millivolts. New onset LBBB also considered as a ST elevation MI. So LBBB also considered here as a MI diagnostic criteria, especially when LBBB is new and associated with elevated cardiac enzymes. So whatever may be the ECG change, cardiac enzyme elevation has to be there to diagnose myocardial injury and cell death. Now, when you're taking ECG, you can actually make out which artery is involved, which coronary artery is involved by seeing this chart. Wherever there is ST segment elevation, you can make a diagnosis of myocardial infarction on that artery. So, for example, we take inferior wall MI. Inferior wall MI 2-3 AVF, there is ST segment elevation. So you can see here. So P wave, PR segment, QRS complex, then ST segment elevation. In 2-3 AVF will make a diagnosis of myocardial infarction in inferior wall, and most of the time this is the occluded artery will be RCA. So that is very important. You can even diagnose the problem in the coronary itself. So that is also very important. Now, ST segment elevation myocardial infarction, there are phases for that. Initially, there will be very tall T waves. There are multiple reasons for very tall T waves that we can discuss afterwards. Then there is ST segment elevation, then ST segment elevation with T wave inversion, then only T wave inversion. After that, if you thrombolize properly or if you do proper revascularization technique, it will become normal. So these are the changes according to time, but there are multiple reasons for ST segment elevation that you can remember like this. Elevation is a mnemonic for that. We are not going to discuss that now. So whenever you are seeing a patient with chest pain, 1 or 2 leads, ST segment elevation or very tall T waves, or for example even Q waves, patient might have had chest pain yesterday night and today is coming with some more chest pain and breathlessness, and you are seeing only Q waves. That Q waves indicates a previous myocardial infarction or recent myocardial infarction. Q wave always indicates an infarct tissue or death tissue. So if you see this first ECG, there is ST segment elevation in V1. Sorry, V1 is there, V2 is there, V3 is there, V4 is there, V5 is there, V6 is there. So all anterior leads are having ST segment elevation. and some reciprocal changes, that is ST depression. You can see here ST depression in 2 and AVF. That is a reciprocal change because anti-revolved myocardial infarction, most of the time you get reciprocal changes. Whereas in this ECG, you are seeing ST segment elevation lead 2, lead 3 and AVF, and some reciprocal changes in V1, V2 and V3. So here it is inferior wall myocardial infarction. These are reciprocal changes. Okay. Now very tall T waves, ST segment elevation with P wave inversion and Q waves. So this is a significant Q wave. More than 25% of the following R wave is a significant Q wave. A significant Q wave is always indicating a negative window, that's a death tissue. So after myocardial infarction, acute phase will be hyperacute tall T waves. Then there is ST segment elevation. Then there is a Q wave formation. So Q wave formation always indicates a previous myocardial infarction or recent myocardial infarction. There normal thrombolysis has not done and that part of the myocardium is dead. Now this is an ECG where you are seeing ST segment elevation in 2, 3 and AVF. Simply you can make a diagnosis of inferior wall myocardial infarction. You are getting ST segment depression V1, V2, V3 like that. So that is reciprocal change. Now here what you are seeing is an ST segment elevation in V2, V3, V4, V5 and some V6 also. So that is extensive anti-revolved myocardial infarction. So ST segment elevation, very tall T waves you can see, but Q waves are not formed. But you can see here in lead 2 and lead 3 there is waterfall appearance. But that we have to see what is the time of the myocardial infarction, how many hours it is over. So if the time lag is there, then it may indicate there is significant cell death, or it might have due to a previous myocardial infarction. But if you see Q wave, normally Q wave has to be like a waterfall. So this is the P wave, and from there it should go down. But sometimes what happens, you may not see the small R wave here, then there is Q wave. So this actually it is not a Q wave, there is a small R. So this waterfall appearance is very, very important to make a diagnosis of Q wave. But if you see clearly here, if you see properly here, you can see some small R waves, some small positives. So that rules out possibly that is not a Q wave. It is very difficult to tell only with ECG. You need to get the history, previous history, patient's echo, all these things are important. Now, non-ST segment elevation means you may get all these changes in ECG, but there is no cardiac enzyme elevation. That is very important. Only if cardiac enzymes are elevated, we can make a diagnosis of myocardial infarction, whether you have ST segment elevation in ECG or ST segment depression in ECG, or you have very tall T wave, or you have very deepened T waves. If cardiac enzymes are elevated, then it is myocardial infarction. If cardiac enzymes are not elevated, then it is ischemic heart disease. Whatever it is, the pathology is almost same. One side it is partial obstruction, other side it is complete obstruction. That's all. Now, myocardial enzymes, CKMB, normally we do in all emergency room. It raises in 4 to 8 hours, return back in 48 hours, whereas troponin I, troponin T, they are faster than my CKMB. 4 to 6 hours it elevates. A slight difference is there, but it come back to normal only after 7 to 10 days. So CKMB is acutely elevated and acutely coming down. Troponin I elevates in hyperacute phase itself, but it ends after 7 to 10 days to a normal limit. So in a reinfarction, CKMB will be better than troponin I, because troponin I will be persistently elevated for longer period. Now you can see here CKMB elevates quicker and come back very fast. But troponin I is as good as or even better than CKMB, but the problem is it remains high for a long period. So in a reinfarction, this may not be useful. Reinfarction, again only CKMB is useful because it is ending here, and after 48 hours again if the patient develops another MI, again it will go high. So that is the advantage of CKMB. But normally we may have to do repeated cardiac enzymes in emergency room. Initially, patient may have chest pain, some ECG changes. Troponin I, you have already seen that it takes some time to elevate. Sometimes it will be negative. So serial CKMB or troponin I may be recommended in acute chest pain. Now, the management all in emergency room always starts airway, breathing, circulation. I'm not going to the details of all these things, but unnecessarily starting oxygen without hypoxemia may be dangerous in myocardial infarction. Only if there is hypoxemia, you have to start oxygen in whatever way you want, whether it is simple nasal prongs, mask, or CPAP, whatever it is. Morphine has to be given in all patients who is having chest pain because morphine relieves the pain and relieves the anxiety. It should be given with metoclopramide. There are some adverse effects for morphine because it can produce bradycardia, hypotension. So we should avoid this drug in inferior valve myocardial infarction, severe hypotension, or bradycardia. So you can remember Monarch for first line treatment in emergency room. Morphine or fentanyl can be given. Fentanyl does not have the side effects of morphine. Oxygen only if there is hypoxemia. Nitrates can be tried to dilate the coronaries, but sometimes it will not work in myocardial infarction. It works only in the ischemic heart disease. Aspirin should be given all patients with coronary pain. Rest and relaxation, anxiety relief, all these things will help the patient. Continuous ECG monitor. So this should be done in emergency room as an acute treatment. Now, after that, we have to discuss what are the drugs we should use specifically for myocardial infarction. So, aspirin and clopidogrel are the two important drugs we always give in myocardial infarction in all the centers, and that can be continued as 150 milligram aspirin, 75 milligram clopidogrel as continuous treatment. Instead of that, nowadays we use ticagrelor. Ticagrelor is always combined with aspirin, not with clopidogrel. So both prasugrel and ticagrelor can be given, but both are preferred over clopidogrel. But nowadays, mostly doctors use aspirin with ticagrelor. Now, various antiplatelets act on various areas in the platelet aggregation. We are not going to discuss all these things. Nowadays, we give aspirin with ticagrelor. Now, beta blocker is another important drug. Suppose patient is having high BP, BP is high, heart rate is high. What happens? If the heart rate is very high, the diastolic phase will come down, oxygen demand will increase by the coronaries, or sorry, for the heart muscles. So you reduce the heart rate by beta blocker, the heart rate will come down. So the diastolic phase will increase and better oxygenation will occur. Coronaries will get more blood. That is the advantage of beta blocker. Long term also it will be very beneficial. So you can give metoprolol 5 milligram IV. You can even repeat 1 or 2 doses. Maximum 15 mg can be given. But if there is bradycardia, hypotension, inferior valve MI, better to avoid this drug. Now, another important drug is always give statins because we have already seen that coronaries will have cholesterol plaques. These are cholesterol plaques. So, cholesterol plaques are there in between. Fibrins are there, platelets are there. That forms the plaque, cholesterol plaque. So, whether the blood cholesterol is high or normal or low, in all myocardial infarction, we have to start atorvastatin 40 milligram. On follow-up, we can give either atorvastatin 40 milligram or 20 milligram of rosuvastatin can be continued. LFT should be monitored frequently. Now, if the patient is coming to a center where PCI is possible, that is angiogram, angioplasty is possible, you have to take the patient for angiogram. You can see here the stent is put and it is dilated. The plaque is compressed sideways. The channel is opened for blood supply, and that can be done in a patient with acute myocardial infarction where PCI facility is available. If PCI facility is not available, then thrombolysis is the treatment. Normally, we use streptokinase 1.5 million units in 100 ml saline given over infusion of 1 hour. or you can go for TPA. Both are equally effective, or alteplase or TPA has got better adverse effects profile than streptokinase. So 1.5 million units, 100 ml saline given over 1 hour, it can produce sometimes hypotension. So in a patient who is having hypotension or hypertension, these drugs should be avoided. Anticoagulants like heparin can be given if the PCI is not possible, or if there is no streptokinase is if streptokinase is contraindicated. This is mainly given to prevent the propagation of existing thrombus or to prevent the deep vein thrombosis. This drug cannot lyse the thrombus. That is very important. This prevents further propagation of the thrombus. Now, basically, you may have to remember some important points in myocardial infarction. Bed rest should be given. Oxygen should be started if hypoxemia. Opiates can be given. Abciximab can be given in some patients, but nowadays we don't use abciximab routinely. We go for other antiplatelets like aspirin, ticagrelor. Now, metoclopramide should be given, beta blockers should be given. You have to give AC inhibitors to prevent ventricular remodeling, and thrombolysis can be used to reduce the clot size. So, remember it as bomber. Now, follow up in the patients. All patients should be started with aspirin, ticagrelor combinations, and you have to give beta blocker. That already discussed. Beta blocker should be given. AC inhibitors are very important to reduce the ventricular remodeling. So, if there is an infarct areas, after sometimes it can dilate. Suppose this is your ventricle. If there is an infarct here in the wall, after sometimes if you don't treat with AC inhibitors, what happens is this part of the ventricle will slowly dilate. So this is called as ventricular remodeling. So that should be avoided, and we have to start AC inhibitors. ARB should be started. And if we are not able to do anything for the clot in acutely, some patients may require bypass graft. So bypass should be coronary artery bypass should be started for that type of patients. Now this chart will help tell you how to manage the acute myocardial infarction in emergency room. You can read it. Now complications, I'm not going to the complication in detail now, but remember most of the patients will have a complication that is very important. Patients can have aneurysm of ventricle if you don't treat properly. Some patients will go to heart failure, and one of the important complications in emergency room is arrhythmias. So you can remember it as Darth Vader. I am not going to the details of that. So we have discussed some basic view over one of the important condition, that is acute myocardial infarction. Myocardial infarction is a complete blockage of coronary. The myocardial tissue is not getting oxygen, not getting glucose. So severe chest pain will be there. That will not be relieved with your routine rest or sublingual sorbitrate. You will have to give morphine or some other pain reliever for that. Then if there is no facility for PCI, you have to take the patient for thrombolysis. You have to give drugs like aspirin, clopidogrel, ticagrelor, or statins, beta blockers, AC inhibitors, ARBs. Then once the patient is stabilized, discharge, you have to advise the patient for regular and graded exercise. Follow up, you can do angiogram and see whether the patient has coronaries are improved or still it is blocked. During the acute phase, if the facilities are available, PCI can be done, that is angiogram, angioplasty, or if the patient does not improve with your all treatment modalities, you can even take the patient for bypass graft. Bypass graft is when the arteries are blocked, either with some vein or some other artery, we are putting a bypass so that the blood supply will be maintained for that coronaries. Thank you.